reflects independent editorial commentary. It is not medical advice and should not replace clinical judgment or review of primary sources and guidelines. The views expressed are those of the host and contributors.
Welcome back to EP Edge Journal Watch. I'm Dr. Sharma, and thank you for joining me for issue 21, May 2026. This is a packed issue. We are going to start with AI-guided redo ablation for atrial fibrillation, specifically in the challenging patient whose pulmonary veins are already isolated. Then we will move into dual-energy lattice-tip ablation for ventricular arrhythmias, and a very important safety cluster around pulsed field ablation and cardiac implantable electronic devices. We will also cover neuromodulation for PVCs, cannabis and atrial arrhythmias, sudden death risk after hypertrophic cardiomyopathy myectomy, atrial fibrillation as a possible ventricular arrhythmia risk marker in heart failure with preserved EF, a simple ECG clue for pacemaker risk in right bundle branch block, and finally the evolving evidence around anticoagulation after apparently successful AF ablation. The thread running through this issue is simple. New tools are giving us new options, but they also require better judgment about patient selection, monitoring, and safety boundaries. So let's get started. Our first study is the RESTART trial. This was a study of redo AF ablation in patients whose pulmonary veins were already isolated. That is the key clinical problem here. If a patient comes back with recurrent symptomatic AF and the veins have reconnected, the strategy is straightforward: re-isolate the veins. But if the veins are still isolated, the question becomes much harder. Where exactly do you ablate? RESTART tested whether artificial intelligence-guided detection of spatiotemporal electrogram dispersion could identify functional non-PV substrate in this durable PVI redo population. This was a prospective interventional multicenter single-arm trial. Patients had prior catheter or surgical ablation for AF and had symptomatic recurrent AF. Importantly, if pulmonary vein reconnection was found during the procedure, the patient was withdrawn from the trial. So this was really focused on the durable PVI recurrence phenotype. The operators used Volta AF Explorer to identify dispersion regions in both atria, and then they ablated those dispersion areas with radiofrequency energy. Empirical anatomic lines were not allowed. Follow-up included visits at 3, 6, and 12 months, with ECG and at least 24-hour Holter monitoring unless the patient had an implantable device. The primary endpoint was freedom from documented AF at 12 months after a single AI-guided repeat ablation procedure. Now let's talk about the numbers. A total of 213 patients were enrolled. The main reasons for premature study exit were pulmonary vein reconnection in 80 patients and non-inducibility of AF in 14 patients. 96 patients underwent a successful index AI-guided procedure, and 93 were included in the intention to treat analysis. Freedom from documented AF at 12 months was 83%, or 77 out of 93 patients. The 95% confidence interval was 74% to 89%. That confidence interval means that based on this sample, the likely true estimate is somewhere in that range. It is a strong signal, but it is still a single-arm study. Freedom from any atrial arrhythmia after one procedure was 70%, with a 95% confidence interval from 60% to 78%. AF termination during ablation occurred in 54% of patients, and right atrial dispersion was identified in 59%. Quality of life improved as well. The A-Fect overall score increased from 66.1 to 85.8, with a p-value less than 0.0001. That p-value tells us the improvement was very unlikely to be due to chance alone. Procedure-related serious adverse events occurred in 6 of 96 patients, or about 6%. So what is the EP Edge take? RESTART is interesting because it studies the exact redo case that frustrates us in practice. If the veins are still isolated, simply repeating PVI is not a strategy. The 83% freedom from AF signal is impressive, but without a randomized comparator, we should not oversell it. In practice, I would view dispersion mapping as a disciplined way to find targets in durable PVI recurrence. I would not yet view it as proof that AI-guided ablation is superior to every other redo approach. For now, this is promising, practical, and worth watching closely. The second paper is CLEAR-VT. This is the early U.S. experience with catheter ablation of ventricular arrhythmias using a dual-energy lattice-tip catheter. The clinical context is scar-related VT ablation, which remains difficult. Lesion size matters, irrigation burden matters, intramural substrate matters, catheter stability matters, procedure time matters. The dual-energy lattice-tip catheter is attractive because it has a larger footprint and can deliver both radiofrequency ablation and pulsed field ablation. But ventricular arrhythmia ablation is a much more demanding environment than AF ablation. CLEAR-VT came from the prospectively maintained Cleveland Clinic VT registry. Patients treated with the Sphere 9 lattice-tip HFpEF catheter from January to September 2025 were analyzed. There were 59 patients in total. 50 had scar-related VT and 9 had frequent PVCs. The catheter was selected for patients with extensive target substrate or prior failure of conventional radiofrequency ablation. In general, radiofrequency was used first. Pulsed field ablation was used as an adjunct, mainly in dense scar with wall thinning or absent contractility on intracardiac echo and low bipolar voltage. The endpoints included clinical VT elimination, VT non-inducibility, abnormal electrogram elimination, and PVC suppression. Now the results. The median age was around 70 years and mean LVEF was 36.3%. Among the VT patients, 40% presented with electrical storm, 30% had prior VT ablation, 68% had recurrent VT despite amiodarone. So this was not a simple population. Acute VT non-inducibility was achieved in 78%. Clinical VT elimination and abnormal electrogram elimination were achieved in all VT cases. For the PVC group, acute PVC suppression was achieved in 100%. PVC burden decreased from 20.4% to 3.5% after ablation. At 6 months, Kaplan-Meier estimated VT-free survival was 69.8%. Let me translate that. Kaplan-Meier analysis estimates the probability of remaining free from VT over time, while accounting for patients who have different lengths of follow-up. The fine-gray cumulative incidence of VT recurrence was 28.4% after accounting for competing risks. That matters because in a very sick VT population, patients may die, receive an LVAD, or undergo transplant before they can have recurrent VT. Fine-gray analysis tries to account for those competing events. There were 3 major procedure-related complications, including 2 major bleeding events and 1 CRTD generator failure after pulsed field ablation about 7.5 millimeters from an LV pacing lead. Another important point, PFA did not reliably create transmural effects in non-ischemic septal substrate. Contralateral abnormal electrograms persisted and required additional ablation. So what is the EP-EDGE take? CLEAR-VT is not just another new technology paper. It shows why lattice-tip ablation is attractive for large scar regions, but it also shows why powerful platforms need careful rules. The efficacy signal is encouraging, but the safety details are just as important. Device interaction, valve entrapment, epicardial fat entrapment, steam pops, and incomplete septal transmurality. I would not summarize this as bigger catheter, better ablation. The better summary is powerful platform, useful tool, new safety playbook required. The third topic is the PFA and cardiac implantable electronic device or CIED safety cluster. This is one of the most practical sections in this issue. Pulsed field ablation has moved very quickly, but many pivotal trials did not include the patients we see every day. Patients with pacemakers, ICDs, CRT systems, leadless pacemakers, abandoned leads, and complex lead anatomy. This group of reports makes the safety issue very concrete. There are several papers here. Nair and colleagues described cardiac implantable electronic device software reset, and permanent generator damage after monopolar lattice-tip PFA. Goldar and colleagues reported asynchronous PFA induced ventricular fibrillation in a patient with an ICD during right superior pulmonary vein ablation. Kovacs and colleagues reported recurrent ventricular fibrillation during lattice-tip radiofrequency ablation near right ventricular ICD coils in VT ablation patients. Kipola and colleagues framed the device standards problem, pointing out that current CIED electromagnetic compatibility standards do not fully address modern ablation energy exposure. Let's break down the signal. In the Nair report, one patient had irreversible CRT generator failure during SVC pulsed field ablation near an ICD coil. Another patient had an AVAIR atrial leadless pacemaker software reset with a transient battery life abnormality that later normalized. In the Goldar report, ventricular fibrillation occurred immediately after PFA delivery in the right superior pulmonary vein. CT imaging showed that the right ventricular lead was less than 1 centimeter from the right superior pulmonary vein. That supported a possible lead-mediated myocardial capture mechanism, essentially a stimulation on T event. In the Kovacs report, ventricular fibrillation was reproducibly induced during lattice-tip radiofrequency ablation near right ventricular ICD coils. Pectoral muscle contraction over the generator suggested that the ICD system may have become part of the RF return pathway, and the device standards editorial made the broader point: modern PFA waveforms and ablation current pathways may exceed what older device standards were designed to test. The practical implications are important. Interrogate devices before and after ablation. Be especially careful when energy is delivered near leads, coils, leadless pacemakers, or generator-connected conductors. Avoid direct or near-direct contact between high-energy ablation electrodes and ICD coils, exposed conductors, leadless devices, or other implanted hardware. If the target is close to ICD coils or chronic lead hardware, consider using a different catheter or a different energy source. For PFA, synchronized delivery may matter, particularly near device leads, because asynchronous delivery can theoretically capture myocardium during the vulnerable period. Use fluoroscopy, ICE, or selective pre-procedural imaging when planned lesions are close to SVC coils, RV coils, coronary venous leads, leadless devices, or left atrial appendage occlusion hardware. The EP-Edge take is this: PFA is not automatically safe just because it is tissue selective. It is still an electrical therapy delivered in patients with conductors. If the ablation catheter is near a lead, coil, leadless pacemaker, or exposed conductor, I would treat the device system as part of the electrical environment. The practical steps are straightforward. Know where the hardware is, avoid direct or near direct contact, use ICE or fluoroscopy when needed, interrogate before and after, and be especially cautious with monopolar systems near coils. This is going to be an evolving area, and I expect labeling, manufacturer guidance, HRS input, and device standards to keep changing. Next is Treat PVC, along with the editorial titled When Sham Works. This was a randomized trial of transcutaneous electrical vagus nerve stimulation for PVC suppression. The idea is appealing. PVCs can be autonomically influenced. Drug therapy is often unsatisfying. Ablation can be difficult depending on the origin, especially with papillary muscle PVCs, LV summit PVCs, epicardial origins, or PVCs that are not easily inducible. So the question was, can low-level tragus stimulation reduce PVC burden? Treat PVC was a prospective, multi-center, double-blind, sham-controlled randomized trial at 7 tertiary centers in China. 100 patients were randomized 1-to-1 to active low-level tragus stimulation at the tragus or sham stimulation at the earlobe. 96 patients were included in the final analysis. The stimulation protocol was 20 Hz, 0.2 millisecond pulse width, individualized intensity, 1 milliamp below the discomfort threshold, and 2 30-minute sessions daily for 6 months. The primary endpoint was change in PVC burden using 10-day ambulatory ECG monitoring. That is important because PVC burden can vary a lot day to day. A 10-day monitor is much stronger than a single 24-hour Holter for this type of trial. Secondary endpoints included heart rate variability, skin sympathetic nerve activity, inflammatory cytokines, adherence, quality of life, and adverse events. Now the results. PVC burden decreased in the active LLTS group from 18.7% to 11.1% at 6 months, with a p-value less than 0.001. That sounds good. But the sham group also improved. PVC burden decreased from 16.7% to 12.6%, also with a p-value less than 0.001. When the two groups were compared against each other, there was no significant benefit of active stimulation. The p-value for absolute reduction was 0.888, and the p-value for relative reduction was 0.105. In simple terms, both groups improved, but active tragus stimulation did not beat sham earlobe stimulation. Adherence was high and similar, 85.4% in the active group and 89.6% in the sham group. Heart rate variability shifted in both groups toward parasympathetic dominance, but there was no difference between groups. Skin sympathetic nerve activity and inflammatory markers also did not significantly differ. Adverse effects were minimal, mainly local auricular rash or redness. So what is the EP-EDGE take? This trial should not push low-level tragus stimulation into routine PVC management. It should make neuromodulation studies better. The active arm improved, but the sham arm improved too. That is the whole lesson. For clinicians, I would not offer LLTS as an evidence-based PVC therapy based on these data. For researchers, the message is even clearer. In device-based autonomic trials, placebo effects, PVC variability, and possibly active sham physiology must be built into the design from the beginning. A good mechanistic idea still has to beat a good sham. The next paper is about cannabis use and atrial arrhythmias. This is a systematic review and meta-analysis of large population studies. Cannabis use is common, increasingly normalized, and often left out of arrhythmia conversations. For atrial fibrillation, atrial flutter, SVT, and atrial tachycardia, that omission is becoming harder to justify. The rationale was simple. Does recreational cannabis use associate with atrial arrhythmias across large epidemiologic datasets? This was a systematic review and random effects meta-analysis of observational studies through April 2024. It was prospectively registered in Prospero. 14 observational studies were included, with more than 81 million participants from North America, Europe, and Oceania. The composite atrial arrhythmia outcome included AF, atrial flutter, atrial tachycardia, and SVT. Subgroup analyses looked at concomitant substance use, region, legalization status, and study design. Here are the key results. Cannabis users represented 1.1% of the total population. Atrial arrhythmias occurred in 12.5% of cannabis users versus 2.7% of controls. Cannabis use was associated with increased atrial arrhythmia risk, with a pooled odds ratio of 1.71. Let me explain that. An odds ratio of 1.71 means the odds of atrial arrhythmia were 71% higher in cannabis users compared with controls in the pooled analysis. The 95% confidence interval was 1.13 to 2.58, and the p-value was 0.012. Since the confidence interval does not cross 1, and the p-value is below 0.05, this was statistically significant. Concomitant drug use showed a higher signal, with an odds ratio of 1.91. Isolated cannabis use still showed increased risk, with an odds ratio of 1.39. Cannabis legal countries showed an odds ratio of 1.93. But there is a very important limitation. Heterogeneity was extremely high, with I-squared around 99.75%. I-squared tells us how much of the variation across studies is due to differences between studies rather than random chance. And I-squared this high means the included studies were very different from each other. So we should not overinterpret this as a precise causal estimate. The evidence is observational. It cannot prove that cannabis causes AF in every exposed patient. Exposure definitions were inconsistent. ICD-coded cannabis use may capture heavier or more medically visible use. Dose, route, THC concentration, chronicity, synthetic cannabinoids, and adolescent data were limited. The EP-EDGE take is straightforward. This is a counseling paper. It gives us enough signal to stop treating cannabis as a harmless social history footnote. In patients with AF, flutter, SVT, unexplained palpitations, or early onset atrial arrhythmias, I would ask directly about cannabis. Ask about route, frequency, dose, co-use with alcohol or stimulants, and timing relative to symptoms. The right clinical message is measured, not moralizing. Cannabis may be arrhythmia relevant, and patients should know that. Now let's move to hypertrophic cardiomyopathy. This study looked at predictors of sudden cardiac death in patients with obstructive hypertrophic cardiomyopathy, or HCM, after surgical septal myectomy. The clinical point is important. Septal myectomy can relieve obstruction and improve symptoms, but it does not remove myocardial fibrosis. And fibrosis may continue to define residual arrhythmic risk even after the gradient is fixed. This was a retrospective cohort from Fuai Hospital in Beijing. It included consecutive obstructive HCM patients undergoing surgical septal myectomy who had preoperative contrast-enhanced cardiac MRI. The final cohort included 1,389 patients treated between 2008 and 2020. The primary endpoint was sudden cardiac death or equivalent after myectomy. The authors used competing risk regression. That is important because in HCM, patients can die from causes other than sudden death, and those events compete with the endpoint being studied. Now the results. The median age was 48 years, and 38.9% were women. Preoperative late gadolinium enhancement, or LGE, was present in 83.9% of patients. The median LGE extent was 4.28% of LV mass. Median follow-up was 3.29 years. All-cause mortality occurred in 40 patients, or 3.03%. The primary endpoint occurred in 16 patients, or 1.8%. That included sudden cardiac death in 11 patients and aborted sudden death in 5. 5-year survival free from sudden cardiac death was 98.5%, with a 95% confidence interval from 97.6% to 99.5%. So the absolute event rate was low, but the question is, who remains at risk? Preoperative LGE extent remained independently associated with sudden death after competing risk adjustment. The subdistribution hazard ratio was 1.06 per percent LV mass, with a 95% confidence interval of 1.01 to 1.12 and a p-value of 0.027. In practical terms, each additional percent of LV mass with LGE was associated with a higher residual sudden death risk. History of sustained VT or VF was also strongly associated with sudden death risk. There are limitations. This was retrospective and single-center. The number of sudden death events was small, which limits model stability. Follow-up was relatively short for HCM risk prediction, and not every surgical patient underwent contrast CMR, which may introduce selection bias. The EP-EDGE take is clean. Myectomy changes obstruction, not scar. A good post-myectomy gradient should not make us ignore preoperative LGE. This study supports keeping LGE extent in the ICD and surveillance conversation after myectomy, especially when LGE is extensive or when there is prior sustained VT or VF. I would not use this paper to create a rigid new ICD threshold. I would use it to avoid false reassurance. The next study asks whether atrial fibrillation is associated with ventricular tachyarrhythmias or cardiac arrest in heart failure with preserved ejection fraction. Heart failure with preserved EF has a sudden death problem, but we do not have the same practical risk framework that exists for reduced ejection fraction. AF is common in heart failure with preserved EF. This paper asks whether AF marks a higher risk ventricular arrhythmia phenotype. This was a single-center retrospective cohort from a cardiac specialty hospital. It included 951 patients diagnosed with heart failure with preserved EF between 2015 and 2022. All had LVEF at least 50%. Clinical variables and outcomes were derived from electronic health record diagnosis codes. The authors used backward stepwise multivariable logistic regression to evaluate associations with ventricular tachyarrhythmias or cardiac arrest. The results were interesting. Mean age was 73.5 years and 52% were women. Coronary artery disease was present in 75% and atrial fibrillation was present in 49%. Ventricular tachyarrhythmia or cardiac arrest occurred in 46 patients, or 5%. AF was independently associated with VTA or cardiac arrest, with an odds ratio of 4.12. The 95% confidence interval was 2.01 to 8.41, and the p-value was less than 0.0001. So statistically, this is a strong association. An odds ratio of 4.12 means the odds of ventricular tachyarrhythmia or cardiac arrest were about 4 times higher in heart failure with preserved EF patients with AF compared with those without AF after adjustment in the model. Coronary disease, male sex, and chronic kidney disease entered the model, but their confidence intervals crossed unity. In other words, those signals were not statistically secure in this dataset. But we need to be careful. This is retrospective, single-center, and diagnosis code-based. Temporality is uncertain. Some arrhythmic events may have occurred before or after the heart failure with preserved EF diagnosis. There was no detailed AF burden, no CMR fibrosis assessment, no ECG repolarization detail, no device-level adjudication, and no medication granularity. Association does not prove that AF causes ventricular arrhythmias. The EP edge take is that this is not an ICD indication paper. It is a phenotype paper. AF in heart failure with preserved EF may be a marker of deeper atrial ventricular remodeling, fibrosis, autonomic imbalance, or comorbidity clustering. For now, I would use this as a reminder to take AF in heart failure with preserved EF seriously as a risk signal, not just a rate control nuisance. The next step should be prospective work with rhythm burden, CMR, biomarkers, and adjudicated ventricular arrhythmia endpoints. Now let's move to anticoagulation after AF ablation. This is the most practice disruptive paper in the issue, but it needs careful interpretation. Current guidelines tell us to continue long-term anticoagulation after AF ablation based on baseline thromboembolic risk, not on whether we think the ablation was successful. But recent randomized trials are starting to test whether that approach may be too blunt for carefully selected patients. This paper was a network meta-analysis of randomized trials evaluating long-term antithrombotic strategies after AF ablation. 4 randomized controlled trials were included with 3,924 patients. Treatment arms included oral anticoagulation continuation in 1,960 patients, left atrial appendage occlusion in 803 patients, and discontinuation of long-term antithrombotic therapy or no left atrial appendage occlusion in 1,161 patients. The primary endpoint was ischemic stroke. Secondary endpoints included TIA, major bleeding, and clinically relevant non-major bleeding. Now the results. The network estimate showed no significant stroke difference for oral anticoagulation versus no antithrombotic therapy. The incidence rate ratio was 0.90, with a 95% confidence interval from 0.02 to 33.85 and a p-value of 0.95. That very wide confidence interval is important. It means the estimate is imprecise because the number of events was very low. No significant stroke difference was seen for left atrial appendage occlusion versus no antithrombotic therapy either. The incidence rate ratio was 0.79, with a very wide confidence interval from 0.00 to 241.01. Among patients who discontinued antithrombotic therapy without left atrial appendage occlusion, pooled stroke incidence was 0.23 events per 100 person years. Let's translate that. Events per 100 person years is a rate. If you followed 100 similar patients for 1 year, the estimated stroke rate would be about 0.23 events. That is very low. In the subgroup with CHA2DS2-VASc score 3 or higher who discontinued therapy, pooled stroke incidence was 0.22 events per 100 person years. A direct comparison of anticoagulation continuation versus discontinuation found no significant stroke difference, with an incidence rate ratio of 1.03 and a p-value of 0.97. However, clinically relevant non-major bleeding was higher with anticoagulation continuation, with an incidence rate ratio of 2.49, confidence interval 1.19 to 5.23, and p-value 0.02. So the signal is provocative, but the limitations are equally important. Event counts were very low. Patients in discontinuation trials were selected, generally younger, preserved EF, lower proportion of women, and often paroxysmal AF, patients with prior stroke, very high CHA2DS2-VASc scores, valvular AF, and EGFR less than 30 were underrepresented or excluded. There were no PFA-era ablation cohorts, and left atrial appendage occlusion comparisons relied heavily on sparse indirect evidence. The EP-EDGE take is this. This is a shared decision paper, not a guideline replacement paper. The data suggests that in selected patients with apparently successful ablation, stroke rates after stopping anticoagulation were very low. But this does not mean stop anticoagulation broadly after ablation. The safe use boundary is still narrow. In practice, I would use a structured workflow, document ablation success, reassess AF burden, exclude high-risk phenotypes that were poorly represented in the trials, discuss bleeding versus stroke trade-offs, and keep reassessing risk as the patient ages or develops new comorbidities. This is becoming a serious evidence-based conversation, but it is not a casual decision. The final study is a practical ECG paper. It looks at the S over QRS ratio in lead 1 as a clue to pacemaker risk in patients with right bundle branch block. This is the kind of paper I like because it gives us a bedside measurement, not another expensive platform. The clinical context is simple. Right bundle branch block is often treated as a right-sided conduction problem, with the left bundle presumed to be normal. But that assumption is not always true. In some patients, right bundle branch block may be the visible part of broader bilateral His-Purkinje disease. In lead 1, the initial rapid QRS forces reflect left ventricular activation, while the terminal S wave reflects slower right ventricular activation. The authors asked whether narrowing of the S wave, expressed as the S wave duration divided by total QRS duration, could identify patients with right bundle branch block who are more likely to need a permanent pacemaker. This was a retrospective single-center analysis of 218 patients with complete RBBB and preserved LVEF. There were 109 cases who received a permanent pacemaker for alternating bundle branch block, Mobitz 2 or complete heart block, or bifascicular block with abrupt arrhythmic sounding syncope. There were also 109 controls with asymptomatic stable right bundle branch block who did not require pacemaker implantation during follow-up. The authors measured PR interval, QRS axis, QRS duration, S wave duration in lead 1, and the S over QRS ratio. For patients with paired ECGs, they compared the oldest available right bundle branch block ECG with the most recent or pre-implant ECG. Here are the results. Controls were followed for about 90 months. Their QRS duration changed minimally from 145.2 to 146.7 milliseconds, with a p-value of 0.67. Their S over QRS ratio decreased slightly from 0.59 to 0.57. Cases were followed for about 89 months. Their QRS duration increased from 139.9 to 147.6 milliseconds, with a p-value less than 0.001. Their S over QRS ratio decreased from 0.52 to 0.43, also with a p-value less than 0.001. An S/QRS ratio less than 0.56 was associated with need for permanent pacemaker. In the machine learning model, the odds ratio was 6.87, with a 95% confidence interval from 3.87 to 12.67 and a p-value less than 0.001. The model had sensitivity of 74.3% and specificity of 70.6%. Sensitivity means the test correctly identifies a reasonable proportion of patients who ultimately need a pacemaker. Specificity means it also correctly identifies a reasonable proportion who do not. The PR interval also increased among cases from 184 to 219 milliseconds, which fits with progressive conduction disease. The limitations are important. This was retrospective and single center. There was no invasive measurement of left bundle activation, so the mechanism is inferred rather than proven. Some control patients may have required pacemakers outside the study system later. Patients with left posterior fascicular block were excluded, so the finding may not apply to all right bundle branch block patients, and a low S/QRS ratio may reflect left bundle disease, his disease, or broader conduction system disease. The surface ECG cannot separate those mechanisms by itself. The EP-Edge take is very practical. In right bundle branch block, a short terminal S wave in lead 1 can mean the problem is not purely in the right bundle. An S/QRS ratio less than 0.56 is not a standalone pacemaker indication, but it is a reason to look twice, especially in an older patient with syncope, PR prolongation, bifascicular disease, or progressive QRS and axis changes. Practical use: when you see right bundle branch block, do not just measure QRS width. Look at lead 1. If the S wave is less than about half of the QRS, the ECG may be telling you that the other bundle is not as healthy as it looks. Let's do a quick recap of issue 21. AI-guided dispersion ablation in durable pulmonary vein isolation in REDO-AF is promising, especially when the alternative is empirical substrate modification, but it still needs randomized validation. Dual energy lattice-tip ablation may improve efficiency in complex ventricular arrhythmia ablation, but the safety playbook matters as much as the efficacy signal. PFA and CIED interactions are now a real safety domain. High-energy ablation near leads, coils, leadless devices, or exposed conductors requires deliberate planning and device verification. Treat: PVC does not support routine low-level tragus stimulation for PVC suppression, but it teaches us a lot about sham effects, PVC variability, and neuromodulation trial design. Cannabis use is associated with increased atrial arrhythmia risk across large observational data sets, so it should be part of the arrhythmia history. Post-myectomy HCM still carries residual scar-mediated sudden death risk, and LGE extent should remain part of ICD and follow-up discussions. AF in heart failure with preserved EF may identify a higher risk ventricular arrhythmia phenotype, but that remains hypothesis generating. Stopping anticoagulation after successful AF ablation is becoming a serious evidence-based discussion, but only in carefully selected patients with continued rhythm and risk reassessment. And finally, in right bundle branch block, a shortened terminal S wave in lead 1 with an S/QRS ratio less than 0.56 may flag bilateral His-Purkinje disease and future pacemaker risk. It is not a pacemaker indication by itself, but it should trigger closer surveillance in the right clinical setting. All references and graphics are available on the LinkedIn newsletter, EP-Edge Journal Watch, as well as on Substack at epedge.substack.com. Questions, suggestions, or concerns, email epedge.cast@gmail.com. Thank you again for listening to EP-Edge Journal Watch. I'm Dr. Sharma. Take care, and I'll see you till the next episode.